Thank you very much. In my presentation, the off-label use is going to be brought up based on the dosage. What I will try to do today is, since resistance is our subject, in schizophrenia, when we encounter resistance, you sort of have to push up a bit more and sort of exert force on this framework. And I'd like to pay tribute to Dr. Esat, and he had told us about 10-12 years ago. He has a long experience in the UK, and it seems on the first day he went to work with a shirt with flowers, and his boss said very quietly, "We come to work with a tie and a normal shirt," he was told, and he always kept that from then on. And while talking about resistance, naturally it's important which criteria is used. At least two different antipsychotics from two different groups and equal value to chlorpromazine. The criteria is using it for 6 weeks. Lack of response is whatever the scale or measure you are using, PANS or BPPRs, and that the points should be less than 25% reduction. But the loss of quality of life, if that continues, then we should recall and consider resistance. As a general outlook or approach, usually we focus on positive signs, but there are different dimensions of resistance: positive, negative, suicide, cognitive, depressive, inquisitive. All of these are lack of response. What should we consider? And tolerance and compliance is important. Whether satisfactory dose has been administered or not, we have to consider comorbidity. As I will stress at the end of my presentation, when the clinical picture is chaotic, usually we're open to error. We ask the patient whether it was good or not, but family and relatives and the patient might say that they have not benefited, but we have to resort to concrete criteria. And we look up literature. For example, off-label use, high dose, combinations of drugs and comparisons of drugs. We have to be careful, first of all, in the survey, when we make a comparison, what was the dosage? The second is, what is the strength, the size of the sample? Because if the sample size is small, any off-label implementation or comparison, not everything will be reflected on the statistics. Duration of the survey is very important, because the dose we increase or the medication we add, we have to know that it will be after a certain lapse, a long lapse of time, that results will be observed, and also the plasma levels of the drug and additional drugs. Now, the plasma level should be controlled. That is important. But in practice, we're not able to do this on the plasma level, but at least it's important we should consider factors that will be influential. And rapid metabolization probability is important. We're not looking for polymorphism, but speedy metabolization in patients, we see that they never reach a steady state level. A slow metabolizer, poor metabolizer, for example, can reach that level. For the extensive metabolizer, usually the level of the drug does not reach a satisfactory level. So we have to consider these two groups. Diagnosis should be revised. Organic reasons should be included. Any comorbidity, if it exists. In resistance, psychotherapy should be added to an effective pharmacotherapy. There are various choices. One is increasing the dose, going above the proposed dose, combinations and additional therapies. Now, dose increase. Why do we increase the dose? Because we're not able to get the expected result. In Turkey and abroad, the same trend exists. In New York state hospitals, these are the standard dose. Risperidone, for example, after many years, are being reduced. Olanzapine is on the increase. 20 is the upper limit, but many people use it over that. In ziprasidone as well, increase of dose. Apiprazole, there's an upward trend. When you're unable to get a response, as what is proposed in the prospectus, usually we try titrating and increasing the dose. What is the mentality behind this? Because even if the patients use the same dose, there are serious differences in the serum levels of patients. The dose and the weight of the patient, for example, normalized clozapine plasma levels, sometimes there are differences between patients that eightfold. Sometimes we say 500 or 600 milligrams are not giving any response, but let alone smoking, even arising from differences of metabolism, such a great variance can exist. And this is an important knowledge behind increasing dose. Another drug which we use frequently, but let me give another example on clozapine. In the Journal of Clinical Pharmacology, the serum plasma levels are assessed. 32 patients were selected because they were using clozapine 900 to 1200 milligrams, especially in smoking males. Doses over 900 milligrams might be necessary. For clozapine, that is the legal upper limit in the UK. Just like lithium, it's not important how much lithium we give to the patient. The important thing is the plasma level of lithium. Probably the same thing holds true for clozapine. This principle does not hold for female patients, or instead it will not be of much use. But there is a rationale for increasing the dose in male patients. In a mean level of 1018, the plasma level in that case is 0.44 milligram. And 440 milligram, it can only go up to 440 milligram. A 26-year-old male patient, he received the dosage, and the patient is taking 800 to 900 milligrams, and that is the limit of 300 milligram effective dose. And the patients are not unable to go up to 300 nanograms, although he's taking 900 milligrams per day. 50 to 100 milligrams of fluvoxamine is added, and the blood levels go up to 600, 700 nanogram. But fluvoxamine, because of enzyme inhibition, increases the existing dose of clozapine. Fluvoxamine additions in the treatment of schizophrenia, it's not the indication the company works on. But one thing, it increases the serum levels, and on the other hand, it's beneficial because then you can use a lesser dose, a smaller dose of clozapine. And we have to include these facts. And also, if the patient is smoking and the same enzyme is inhibited by smoking and can reduce serum levels, and we know most of our patients are smoking, clozapine's upper limits should be tried, at least in those people that smoke. So for olanzapine, we can say the same things. If we compare the two, this short comparison, but 50 milligram olanzapine, serum levels and response rate did not show any relation. What I want to stress is that the number of smoke and olanzapine does have a correlation. And because olanzapine uses in the same way, the same channels, the olanzapine serum plasma levels are reduced in people that are smoking. And I will touch on data on high doses as well. As for dose increase, haloperidol is a very basic medication, but high doses in haloperidol do not seem to give results. I really want to stress that, because anything over 30 milligram are not used in practice. Robert Conway has a study, the olanzapine 10, 20, 40 milligrams were compared. They say between the doses there is no great difference. If the PANS was in clinically severe patients over 110. When you compare 40 to 10 milligram, 40 milligram olanzapine provided an added benefit, but a higher dose in the same manner does disturb the lipid profile and weight gain. When we compare olanzapine and clozapine, these are resistant patients. That is disadvantageous to olanzapine and an advantage to clozapine. In 3 studies, olanzapine, just like clozapine, has been shown to be as effective. In Conley's study, those went up to 40 milligrams. That usually it's the normal trend. Clozapine shows a slight superiority. Kumra's work, the study that does not find olanzapine effective in the early onset of schizophrenia, 12 to 24 weeks, around 40 patients were included, and those that did not respond to olanzapine after 12 weeks, when clozapine was administered, clozapine showed superior to olanzapine. Elif and Aygün and Meltzer is the principal author in this publication, high-dose olanzapine, whether it was as effective as clozapine for 6 months, 30 milligrams of olanzapine were compared with clozapine, but only in the PANSS score, the weight gain, olanzapine is more negative. There's more gain weight with olanzapine compared to clozapine. So when olanzapine doses increased, at least it is equal in efficacy to clozapine. Now, combinations are frequently used, especially in hospitalized patients. Usually, before the patient is discharged, we resort to polypharmacy to overcome exacerbations. But after the patient is discharged, this level goes down, and in ambulatory follow-up, it does go up, down a bit more. For example, the combinations could be typical antipsychotic combinations, 2 of them, and could be clozapine. Without clozapine, it can be combined with typics and atypic drugs. What could be the rationale behind it? With different mechanisms, we want to influence the pharmacokinetic. We try to increase the efficacy on the same receptor by using 2 drugs that bind on the receptor, and we want to increase the plasma levels. Clozapine can change from country to country. It's lower in the United States. In Germany, it's 50-50. Clozapine, especially in resistant cases, is used at a high degree in combinations. Atypic medications plus clozapine, and as far as I know, there's one study. It was carried out with sulpirate in 97. This is important. 600 milligrams sulpirate is added compared to placebo. There is a significant reduction in the BPRS score. And I believe the whole world is basing it on this publication. But when we consider the placebo group and their background, we see that this is a worst prognosis group because they're hospitalized. And sulfate was administered to the good prognostic group, whereas the placebo had the more severe cases. Clozapine plus atypic combination, the most important, clozapine plus risperidone combination. We have 3 studies on this, 2 of which was in October 2005. Results were published, and Elif and together with Meltzer and with Dokuz Eylül University. 6-week study. As we can see, risperidone was added As a response criteria, they have 20% reduction. But in the placebo group, the decrease is high. Both groups have a positive effect, but the placebo group has a higher decrease. So that's a negative study. On the American Journal, it's a 12-week study, and at the same levels, but it's a longer duration in their work. It's more detailed because before they also tested resistance or lack of resistance to clozapine, and then they randomized it to placebo or clozapine. There are similar results derived in all these studies, but the American Journal positive studies difference that the benefits of adding risperidone was shown. And when we consider the details of the study, you will not be able to read it from there, but let me point out. In milligrams, clozapine milligram as a dose in the combination group is 528, in the placebo 400 milligram. Now the placebo group is significantly taking a lesser amount of clozapine, even though it is as if this is for the benefit of the combination, but methodology-wise we should take care on that detail. In New England Journal of Medicine from Canada, and there are more number of patients, the duration is longer, clozapine was administered to stable patients or those that have been taking clozapine for a long time. Risperidone or placebo was added. And this is important for off-label use. Fasting blood levels were higher in the combination group. While adding two drugs, we should not think that it will not have a damage, it will be beneficial, but the metabolic parameters will also be influenced. We must consider that as well. Finally, there are two other studies I'd like to mention, and this is outside of FDA ratification. This is the Finnish group. In the schizophrenic research, a meta-analysis was published. 5 randomized placebo-controlled studies were included, 100, 200, and going up to 400 milligrams, where lamotrigine was added. And in the total point, positive and negative symptom points, addition of lamotrigine did create a difference. What's the rationale behind this? But in this meta-analysis, compared to the starting point, after adding lamotrigine, clozapine blood levels went up. Perhaps lamotrigine has an advantage or an effect like the addition of fluoxamine. It's not something I use a lot in practice, but after reading this, I will resort to lamotrigine more frequently after having used other options. Now, this is a study from Turkey, from the Gata Military Hospital Group, and it appeared in the International Journal of Clinical Pharmacology. In ginkgo biloba extract 110-20 milligram were added to the resistant schizophrenic patients. But in the SUNS points, in the group where the ginkgo biloba was added, there was a significant reduction. As I have pointed out, resistance is not only positive, but the negative resistance exists as well. So we should keep in mind the existence or use of ginkgo biloba. And I think if we use a scale for resistant patients, it will facilitate our work. They could give us an idea in total, but there are certain weak points. And for our patient, we should establish an algorithm. A personal algorithm will be beneficial. Thank you.